So the Office of School Health, for those of you who don't know, the Office of School Health is a joint department. It's actually very unique between the Department of Education and the Department of Health and Mental Hygiene. And so Office of School Health does everything that's health related in our schools, everything from nurses and doctors, adolescent health centers, our vision program, oral program, etc. And then school mental health comes under that program as well, just so to give people an overview. School mental health services actually started back in 1988 and 86 with a handful of mental health providers in the community to offer what we call school-based mental health clinics. So there were about 50 schools at the time that started it. The idea was that students may need extra treatment or counseling that special ed couldn't offer at the time. So we jump almost 20 years later in 2005, and the school mental health program was born. That's where I came in. I've been there for about 12 and a half years now. And I was one person for 7 years. We had a second staff in 2007, so we went up 100% in 2007. And now at capacity we'll be 134 staff across New York City schools. So we've gone from about 50 schools in 1988. We'll be in almost every school this coming school year. So it's really been a major trajectory, a major growth, and a lot of it has to do with Thrive NYC. So what we do is mostly we partner with community providers. There is the DOE, there are guidance counselors, social workers, SAPIS workers, etc. But I want to be clear, what we do is we partner with our community providers, social service agencies, mental health agencies, and with hospitals to bring in mental health resources into the schools. Our goal is really to implement and create effective ways of increasing school-based access to mental health services. We don't use a cookie-cutter approach. What I mean by there are those who think, well, every school in New York City, and there's 1,800 of them, should have a school mental health clinic. That means it's on-site treatment, overseen by the State Office of Mental Health, but we don't see it that way. Just like there may be 50 people in this room, I wouldn't all give you the same diagnosis or the same treatment if that was to be so. We look at our school as a client. And we want to look at the needs of the school. So the first thing that we do in any school is we do a school mental health needs assessment. We look at the school's priorities, the school community needs. So what does that mean? That means parents, that means students, that means where that school is located, what are the resources in that community, what resources aren't there. So we sort of look at the gaps as well. We sit down, regardless of the program that we do, and we come up with a needs assessment. And we try to facilitate that assessment by bringing in outside resources if funding is available for the various models. Or if not, we connect them to community resources so that we cut down some of the red tape, the waiting lists. We do a lot of pro bono work with our partners out in the community. Many schools aren't quite aware of what the DOE has to offer. Right? There's 1,800 schools out there. You can imagine what that's like for a principal on a daily basis, or a guidance counselor who's got a caseload of 80 kids. What do I do? Where do I go? So we've created some models and some interventions to help the administration, help the students, and help the kids. For the most part, our services under the mental health services are not student-level services. So what do I mean by that? That means that many of our services are for the administration, for the teachers, for parents, and when we bring mental health services into the schools in some of our models, then it becomes student level. So I want to make that clear, and we can talk some more about it. So how do we do it? We use a 3-tiered public health model. Some of you might have seen this. Again, it's a public health model. You might have seen this if you're familiar with PBIS, if you're familiar with other medical models. So if we look at the first tier, those are what we call universal services. Those are the kinds of services that we offer to anyone and everyone in the school. So you look at bullying programs, school-wide programs, teacher trainings, parent trainings and workshops. Those are universal interventions, open and access to all, referrals to outside agencies. The second is selective. These kids are selective because they're at risk. They're at risk for abuse, neglect, dropping out. Often these students are at risk of their behavioral or emotional challenges worsening. So one of the abilities through Thrive NYC is that we act early. Most of our interventions are preventive interventions that we do. Here's where you're going to see your group work, your restorative circles and justice, de-escalation, those kinds of interventions. And finally, the top of the tier, those are your targeted interventions. That's the direct service. So if there is a school-based mental health clinic on site, we're going to offer that. That's where counseling comes in. That's where crisis situations come in because it's targeted to that individual student and or their families. So what are the models that we have? So let's go back up to this slide. And again, I only have a brief time to talk about it. So let me tell you, our community school initiative, some of you may be familiar with the community school model. It's a model to bring in resources from the community to deal with attendance, to deal with parent engagement, help managing the school and bringing all kinds of activities, including mental health services. Interesting, since we started back in 2016, we had about 1,800 services in these 130 schools. Last April, we had over 19,200 services that were done. Those are almost 20,000 services that students and families never got before. It's a really amazing feat. These are in 130 schools. The consultant program. The consultant program was created this year through Thrive NYC. A capacity will be in 973 schools. Again, this is not student services. These are services for the administration. What we do is we promote mental health awareness, destigmatizing campaigns. We connect schools to resources in the community and families to resources in the community. A lot of what we do is postvention, if you're familiar with that term. After a crisis, the schools are left hanging sometimes. The DOE deals with the crisis, but our consultants can go and help them deal with the grief or the bereavement and also connect them to other resources. We do a lot of training, but the emphasis is on consulting. It is not treatment-oriented. Then we have the School Mental Health Prevention and Intervention Program. This will be starting this fall. These are in 49 high-need schools. These schools tend to be campuses with 2,000, 3,000 students that have not had a lot of mental health services, or we're going to be bringing services on site there as well. The 100 Schools Project, that's overseen by the Jewish Board of Family and Child Services in conjunction with 4 NYC-based performing provider systems. This is a school climate model, so that means there's coaching involved, there's training, classroom observation, again, referrals that can be done, but there's no treatment on site with that program. The city has a school response team. This is in partner with the mental hygiene and the DOHMH. It's another school climate type of program. It's preventive, preventing kids from getting to that top tier through various interventions by a mental health agency with about 5 schools. And just finishing up, there's the school-based mental health clinics. Currently, we have about 265 across the city. There's always a possibility of creating more. These are overseen by the State Office of Mental Health. And we have about 60 mental health providers over in schools with the mental health programs in the clinics. The STARS program, that's screening the at-risk students. Nurses came to us and said, we're seeing kids we've never seen before who are self-mutilating, depressed, anxiety. I know how to do a catheter. I know how to give an EpiPen, but I'm not a clinician. So we do a training now for every beginning of every school year. We do an orientation with the nurses. It's a 2-day training. We use the Columbia Suicide Screening and the SDQ. And then it's about referring and identifying students that only go through the nurse's office. And finally, through Thrive NYC, we've been able to do some fantastic universal suicide prevention training. Many of you have heard of Youth Mental Health First Aid. We also do Making Educators Partners. These are specific suicide prevention for schools. And then finally, the Atrisk Training, which is an avatar training that any teacher can have to how to learn how to approach students, identify students who may be under psychological stress. Let me see here. Right. So I explained the universal, the selective, and the targetive questions. The last thing I want to say before we open it up for questions, and I may have time to go into some of these in a little more detail, is again, if you think about it, we are now, there are 1,700 nurses in New York City schools, and now we'll be in over 1,700 schools. Some schools, as you know, are 100 kids, 100 students. Some of them are 3,000 students. So we, in essence, we now have the ability to enhance mental health services and interventions in all New York City schools that we work with. I think it's a major accomplishment. We were given about 1.5 years to do that. It's been a lot of hard work and effort by so many partners at the DOH and DOE and other city agencies. And we're really moving into our second year. So in terms of data and things of that nature, I can try to answer some of those questions, but I think you have to give it, like any good program, you give it 3 years to see where it is and how it plays out. So with that, I'm going to end it and open it up for questions and comments.
So thank you, Mr. Bloom. Thank you for your time. So now's the time for questions. Yes. So once again, if you're in the room with us, if you have any questions you've written out, just raise them in the air. Someone will come around and pick them up. I have a couple of questions here as well to start. So Mr. Bloom, what are some of the challenges you believe schools face in addressing youth mental health issues kind of going forward?
Sure. Well, you know, students come in with all sorts of issues. It's not just about, we know it's about ABC and about learning and writing and arithmetic and all of that. But you have to think about it from a cultural point of view, that each one of us in this room, right, the Bloom family, the Jones family, the Rodriguez family, for the first 5 years of our lives, we're in that family and we're learning the culture of that family, right? We have our norms, we have our values, how we get along, how we don't get along, etc. And all of a sudden, you're 5 years old, you're 6 years old, you go to PS 101 or PS 102, and PS 101 has their own culture, their values, their norms. And here's where we start seeing some conflicts that can enter that. And schools often are the place where we start to see some of these mental health issues first. So the economic issues, the poverty issues, I think stress and trauma that many of our families deal with. It's not just that child comes into the school with their lunch box and their backpack, but it's sort of like they're bringing in all of those issues with them. And I think the challenge for schools is how to identify students quicker that may be dealing with psychological stress, maybe suffering from depression. For those of you in mental health field, we call them sometimes internalizers. We don't see it. We can always see a black and blue mark. We can see if a child is crying. But if they're dealing with anxiety, they can't comprehend what's being taught. They can't concentrate to what's being taught. They can't listen. If right now any one of you had a toothache, there's no way you're listening to me. You're thinking, oh, I got to do it. But you can go to the doctor, you can get it done. But if a kid is thinking, you know, is dad going to come home drunk tonight? Or what's going to happen in the shelter when I come home, because it's kind of a random system. They can't pay attention that way. So we're not asking schools to become therapists or treatment centers, but we are looking to make sure that teachers and administration see the signs and symptoms, recognize some of these things, and then can make the right connections. And I think with our consultant program and some of these other programs we have, they have some of the tools to do it now.
Thank you. As we are seeing an alarming increase in suicide attempts in young adults, is there more of an effort or attempt to bring more student-based services into schools?
Yeah, that's a great question. I know that, as I understand it, suicide for teens used to be the third cause of death. Now it's the second cause of death. And some of you may know that Netflix released that a wonderful series, 13 Reasons Why, without a lot of, seemed to me anyway, and a lot of kind of glorifying suicide. Sometimes there's suicide contagion that goes on. So I think the DOE has really put a lot of their efforts, and again through Thrive NYC, we've been able to do that. the the at-risk training. That's something that's open to everyone. Again, it's a universal intervention. From the lunchroom lady to the principal. As long as there's a computer for an hour, they take this training and they learn about the signs and symptoms of suicide and how to approach. Because we say suicide, people in this room may be still nervous, and I don't know your mental health backgrounds or your trainings, but it's something a nurse never had to talk about, or a teacher. I don't want to do it, I'm going to give it to this teacher. I don't know, send them down to the guidance counselor, and there's a line out the door. So we want to make sure that everyone is prepared to do that. We've had over 8,000 teachers and administration take that training. We also have youth mental health first aid. This is a little more intensive. It can be a 1-day or 2-day training that we offer that, again, looks at psychological stress and how to respond for a psychological emergency, just like some of you here may be trained in CPR. This is sort of the mental health CPR with youth mental health, so we have that to offer. And again, the third thing is many of the counseling managers in the DOE, some of our school mental health managers, have been doing the Making Educators Partners. Why? Because you have to remember, when it comes to suicide, there's not one entrance. I'm going to do that training and then, okay, I'm going to remember it. Because you never know, the next day, after that training you just had, some kid you're going to see is going to come up to you and be anxious or be suicidal. So for suicide, you have to have multiple pathways. And in a school, that means avatar training, classes, curriculum, presentations in front of the teachers, making sure that there are 2 or 3 different kinds of interventions available to schools, as well as a lot of resources and toolkits.
Thank you. Do you have any programs that engage with parents before crisis that help increase understanding and awareness?
Right. Another great question. So that goes back to those universal interventions. I don't have the numbers in me. I know through our community schools, there must be 3 to 4 parent trainings and offerings on a yearly basis. And one of the things about now having a staff to go into the schools, vis-a-vis our school mental health managers or consultant program, is we're working now with the school support team in every school. What are your parents' needs? What are your family needs? Again, it goes back to prevention, and that's key here. Do they need one of the biggest workshops that we do, most popular that agencies do, is test anxiety. Who doesn't have test anxiety? You know, I'm always asked this question, Scott, where would you put a mental health program in New York City schools? And I always say, where wouldn't you put? I don't care if it's the Upper East Side or Mott Haven or Staten Island or the end in the Rockaways. Kids are kids, and they're going to be dealing with these kinds of issues. And so test anxiety, helping parents to help their kids, that's like a number 1 bestseller, so to speak. There's also helping kids with homework, helping parents understand what's a real crisis situation and what's sort of typical adolescent behavior or typical elementary school behavior. When to ask for help and when, you're a parent, and how we can help you. So there's lots of availability, and I think parents, and I love when there's more parent involvement, parents can be involved and find out. Actually, one of the things we're doing this year, working with the DOE, is going to be, DOE is looking to put the mental health services, the enhanced services, on their website for each school. If you go into the DOE is overhauling their website. It's going to be parent-facing. So it's going to be, I think it's going to look pretty good here. And so parents will have more of an opportunity, I think, to get involved that way.
Thank you.
Sure.
We have a question from online. I work with adults with dissociative identity disorder, where 1 to 3% of the population of North America meet that criteria. It takes an average of 7 years for adults to find competent care. Given the complexity and misunderstanding around DID, how does the DOE work to support youth with this and other complicated disorders?
Wow. Interesting question, and I appreciate the complexity of what the viewer has mentioned. I am not as familiar with that diagnosis myself. However, by having in the schools that have a school mental health clinic, these are all designated by the State Office of Mental Health. They are DSM-5 appropriate. They have trainings ongoing in services. They have psychiatric capability, psychomedication as well if needed, and this all can be taken place in the school. So students who may have that disorder or other types of disorder will get the care that they need because, again, these clinics are connected to the community, as I said before, hospitals, community mental health programs, and social service agencies. With some of the other programs where it's not treatment on site, whether it's the consulting program, the 100 Schools Project, or the school response team, they are affiliated with mental health agencies. So again, they can bring, if that's brought to our attention through the school support team, those coaches or those consultants can then connect families to the proper services. A lot of what the consultants did this year was just that. They cut some of the red tape. They brought in kids. We can tell you stories of schools who've tried for 2 or 3 years to get a student the right service. Our consultant has the time, right? Doesn't have a large caseload because the school is their client. So they go, they can go to the community service, they can make the connection, they can come back to the school, they can say, here, we have an appointment set up, Mrs. Jones, please take your son. And that's how we do it. So those connections to services, I think, can happen faster. And you can get the right service for the right need.
Okay. Last question. How does your Universal Services Program affect school climate?
Right. Well, I think that's exactly why we put it in there, because we see a lot of positive results. We're getting a lot of good feedback from our schools who've never had that ability before. Mental health was not in the previous, I would say, 5 years ago and longer, because again, I've been involved almost 13 years now, mental health was not on the radar. If a school wanted to do it, that's fine, they could do it. It was not on the radar. Now it is a sea change that we're starting to see. When I have principals say, I want more universal services, my selective services, I got it pretty good and I know my target. Well, they're speaking my language and I'm speaking their language. That means that, just like with a client, they've internalized the work that you've done individually. So that work that we do. So we start to see, we're looking at, in terms of better school connectedness, the DOE does a survey at the end of every school year from principals and students and families about the school climate. So we as these programs are emerging, we do look to see more positive. I can tell you we get a lot of positive feedback. We get about a dozen different success stories on a monthly basis from these different programs that talk about the positiveness of having universal interventions. It's the first step. This year we hope to do a campaign within the school, so we make sure that teachers know who those enhanced mental health services are, who are the folks they should go to, because teachers are extremely busy. Stop them in the hall. Mental health, yeah, I think they're around. Maybe they're downstairs. I don't know. Do we have something here? And there's a used sign outside saying this is a community school. So we have to start doing better with that. And I think with our partners, we will.
All right. So thank you, Mr. Bloom, for joining us today.
Thank you very much. It was a pleasure. Thank you.